Hello, good morning, and welcome. Sorry, it's good afternoon eventually. I'm Dr. Himanshu Mathur on behalf of Jaipur Rehab. I would like to welcome you for the second topic of the first module of the online free biomechanics classes with Dr. Himanshu. First of all, before starting anything, I would like to wish all of you, everybody out there who are watching me, I would just like to wish you a very happy Teachers' Day. 5th September every year is celebrated Teachers' Day in the memory of the teacher of the nation, Dr. Sarvapalli Radhakrishnan sir. And I would like to convey deep regards to all my faculties, all my teachers, all my seniors, and everybody who have been associated with me in my journey. Thank you so much, everybody. I would like to convey deep regards to all of you. Thank you so much, and to all my students also, because without students we cannot be good teachers. Nobody can be a good teacher without students. Thank you so much, everybody who are wishing me. Thank you so much. Happy Teachers' Day to everybody, because students play an equal role in the life of a teacher in becoming a teacher, right? Thank you so much, everybody. So today, let us get a little more involved in the biomechanics of the knee joint. We have to start with the knee joint. Okay, let me share the screen. Start with screen sharing. Just a second. All right. Let me give a brief, small introduction of myself. I'm Dr. Himanshu Mathur, working as an assistant professor in the Department of Physiotherapy, Jaipur National University. I'm also working as a chief physiotherapist for my physiotherapy clinics and chief physiotherapist and director at Jaipur Rehab. So here we have come with the biomechanics of the knee joint. Knee joint is eventually considered to be one of the largest joints of the body because of eventually the weight which falls onto it, and it is one of the quite distal joints through which we disperse the whole body weight into the ground. Okay, so it is one of the largest joints of the body and one of those joints which bears largest amount of weight also. Okay, so it is a very, very, very important joint with respect to weight bearing, with respect to the class of joint we are talking about. It is a condylar variety joint because the condyles of femur articulates with the condyle of the tibia. Okay, we have a very classically convex condyles of the femur, and we have quite relatively flat surfaces of tibia with which the condyles of the femur articulates. The articular surfaces of the tibia are quite flat. Because of that, we require some structure that could dampen it, that could create a concavity, जो कि एक गड्ढा बनाए वहां पे, क्योंकि बड़ा मोटा सा होता है ना, ऐसा ऐसा मोटा सा उभार होता है कंडाइल ऑफ फीमर का. तो अगर बिल्कुल फ्लैट सरफेस है तो ज्योमेट्रिकल आर्टिकुलेशन नहीं होगा. देयर विल बी नो geometrically articulated joint if we directly keep the condyle of the femur over the tibia. So what do we require here is we require a structure that could be somewhere geometrically congruent with that particular structure. Okay, that is why we require other soft tissues which dampen, which creates a concavity around the condyles of the tibia. Okay, so that is why we require various soft tissues, जिनको कि हम discuss करेंगे अभी थोड़ी देर में. Okay, so before discussing all those things, let us come on to the articular structures. Last time की तरह मैं बता देना चाहता हूँ एक बार आप लोगों को फिर से. I'll not be going into the anatomy of it. We'll be discussing the osteological features that are important based upon the biomechanics of the knee joint, right? We'll not be discussing any anatomy over here. Okay, we'll be discussing important biomechanical characteristics, because I consider that you people know the anatomy. Okay, that is why we are moving a little forward towards the biomechanics of it. Okay, coming on to the articulating bones. So the proximal articulating bone is your femur. Rather, it's better to say that the condyles of the femur are the articulating bones here. Okay, you can write your questions in the comment box. I'll be taking it in the end. All right, so you can see a very beautiful bone, very beautiful femur here, right? So this is the head of the femur that articulates with the hip joint, okay, acetabulum. This is the distal end of the femur that makes the knee joint, okay. There is a larger medial condyle and there is a relatively smaller lateral condyle, okay. Now, why do we require a larger medial condyle? Because the mechanical axis or the weight of the weight line or the COG, they lies in pretty much center, okay. And if they are lying in pretty much center, the individual weight axis or the mechanical axis of the lower limb would be directed a little more medially. अगर हमारी COG सेंटर में है तो जितना भी वेट का कंसंट्रेशन होगा वो टुवर्ड्स द सेंटर होगा, टुवर्ड्स द सेंटर होगा. तो हमारी जो इंडिविजुअल वेट एक्सिस या मैकेनिकल एक्सिस है लोअर लिम्ब की, वो भी माइग्रेट हो जाएंगी मीडियली. अगर वो माइग्रेट हो जाएंगी मीडियली तो ज्यादा वेट कौन बियर करेगा? लार्जर वेट विल बी बियर्ड बाय द मीडियल एस्पेक्ट ऑफ दैट पर्टिकुलर जॉइंट. ठीक है, बिकॉज अच्छा आपको याद हो पिछली बार हम लोगों ने हिप जॉइंट की बात की थी, तो हिप जॉइंट का ओरिएंटेशन भी मीडियल है, बिकॉज द हेड ऑफ द फीमर इज ओरिएंटेड मीडियली. ओके, दैट इज व्हाई द एसिटाबुलम इज ओरिएंटेड लेटरली so as to articulate with the head of the femur. Okay, अब वो भी medially है तो वो medially ही weight को नीचे distribute करेगा, और अगर वो medially ही weight को distribute करेगा तो knee joint का वो हिस्सा जो larger weight bear करता है, that will always be the medial condyle. And so as to make the condyle, the structure of the condyle such that it could distribute weight properly. This is the reason why the medial condyle of the femur is relatively larger. Okay, क्योंकि इसको ज्यादा वेट बियर करना पड़ता है, तो हमारी एनाटॉमी इस तरीके से डेवलप हुई है कि इसको मीडियल कॉन्डाइल को रिलेटिवली लार्जर बनाया जा सके. ठीक है ना, क्योंकि ये ज्यादा वेट बियर कर पाएगा, इसमें ज्यादा कैपेसिटी होगी वेट बियर करने की भी और वेट डिस्ट्रीब्यूट करने की भी. ओके, और यही कारण है कि जो मीडियल कॉन्डाइल या मीडियल प्लेटू ऑफ द टिबिया है वो भी इसीलिए ज्यादा है. ओके, this is the only reason why we have larger medial tibial plateau, or you can say the medial tibial condyle also. If we would have had smaller medial tibial condyle, the weight which is falling or the force which is coming from superior would be the same. Okay, but if the area would have had shortened or lessened, the force per unit area, that is the pressure, would have increased too much. Now, if you have a greater amount of pressure at a particular condyle or in a particular compartment, you would have developed early degenerative changes. और early degenerative changes को हम क्या कहते हैं? Osteoarthritis. Okay, चलो अब पढ़ भी लेते हैं जरा कि हमने क्या लिखा, थोड़ी सी मेहनत की हमने, तो हम जरा देख लेते हैं क्या है. The medial condyle extends farther distally than the lateral condyle. हमने बात कर ली है इस बात की. The shape and size of the tibiofemoral articular surface of the medial condyle distinguish it from the lateral condyle and influence the motion of the tibiofemoral articulation. इस लाइन को अभी छोड़ दो, मैं अभी थोड़ी देर में बात करूंगा. ये कह रहा है कि क्योंकि ज्यादा नीचे की तरफ खिसकता है मीडियल कॉन्डाइल, ज्यादा बड़ा होता है मीडियल कॉन्डाइल लेटरल कॉन्डाइल से. दिस इज द रीजन व्हाई कि मीडियल कॉन्डाइल का ये स्ट्रक्चर और ये पोजीशन वहां के पे होने वाले मूवमेंट्स के ऊपर असर डालता है. इट हैज अ सिग्निफिकेंट इफेक्ट on the movements which takes place at the knee joint. We'll be discussing it once we discuss the screw home mechanism. Okay, now the medial condyle's articular surface for the tibia is longer from the antero-posterior than that of the lateral condyle. We discussed it because it has to increase the surface area for articulation, so such that it can lower down the pressure, so that it could lower down the chances of early degeneration. All right. Although the medial condyle is convex from anterior to posterior and its curvature is a little variable because it starts with a classical convexity, then it gets a little flattened, and then the convexity starts again. The little flattedness is because of the efficient weight distribution. The weight distribution has to be a little more efficient when we talk about the inferior surface. It is flattened because of efficient weight distribution. All right. The lateral condyle's articular surface for the tibia projects posteriorly more in the sagittal plane than the medial condyle. Okay, because of the reasons we'll be talking when we'll be discussing the motion at the knee joint. Okay, so it is a very simple bone, long bone, slender bone. Acha, femur is also had a convexity from anterior. Okay, sagittal plane mein it is a little convex. It is a bow-shaped bone. Okay, because again of the efficient weight transfer from the hip joint to the knee joint. All right. Moving forward towards a beautiful bone, another beautiful bone, that is your tibia. Tibia is a wonderful bone, I must tell you. Whenever you'll study the anatomy also, and whenever you'll study the histological structures of the tibial bone. Okay. So the proximal articulating surface, you have a lot of structures over there. If you can see this this diagram, this is the lateral condyle of the tibia. This is the medial condyle of the tibia. Okay. Medial condyle, you can see it is relatively larger as compared to the lateral condyle. See, medial condyle is relatively larger because it has to articulate with a larger medial condyle of the femur. Okay. Now, this is the area, it is called tibial tuberosity. It is an outgrowth, and this outgrowth is a result of Wolff's law. And all those people who know Wolff's law will write it in the comment box. Wait, let me ask for my mobile phone. Your mobile phone. Okay. All those people who remember what is Wolff's law, keep writing it into the comment box. I'm trying to see this. Okay, I'll check it in my mobile phone because I'm not able to see it right now. Okay. All right. Wolff's law. Arey, nobody has written it. Right. What is Wolff's law? I am saying that tibial tuberosity, the formation of tibial tuberosity is a result of the Wolff's law. Tell me what is Wolff's law. Write it down. I'm giving you time. From the next time, I'll be asking questions and I'll just give you 10 seconds to write. What is Wolff's law? Write it down. The bone grows very good. The bone grow larger where the force is maximum. It is correct. So Wolff's law suggests you that the growth of the bone would choose a direction in which the force is laid upon. Okay. Bones will adapt to the stress placed on. Correct. All those people who are writing, they are correct. Very good. I am pretty happy that you people know what is Wolff's law. Okay. So after Wolff's law, I am giving a small homework to you. You'll also go and see what is the law of parsimony. I'll ask you what is law of parsimony in the next class. Okay, you'll go and read what is law of parsimony. It is upon the recruitment of the muscles. All right. It says that whenever you have smaller forces or smaller torques, the work that require lesser forces or lesser torque, then our central nervous system employs very less force or very small muscles. Okay. But if the work is large, if the force that has to be employed is larger, in that case, our central nervous system employs larger muscles, the muscles with larger cross-sectional area. Okay, so that is what is the law of parsimony. I'll be asking you in the next class. Okay, very good to all the students who are writing it. Very good. So let me try to read what I have written. Okay, The proximal articulating surface of the tibia is considerably small with respect to that of the femur. We know that. Okay. Yes. Very good. Very good to all the students. You're writing it so well. That is correct. If anybody who don't know what is Wolff law, please write it down somewhere right now only. Okay. Please write it down. Both the Wolff's law and law of parsimony. Okay. They are very, very, very important concepts of biomechanics. किसी को अगर लॉ वुल्फ्स लॉ और लॉ ऑफ पार्सिमनी नहीं याद था तो लिख लो उसको कहीं पे, ठीक है ना. जो मैं चीजें कंसेप्ट बताता जाऊंगा, जैसे हमने लास्ट वीक में डिस्कस किया था, वी डिस्कस द कंसेप्ट ऑफ टॉर्क, वी डिस्कस द कंसेप्ट ऑफ लीवर्स, वी डिस्कस द कंसेप्ट ऑफ मोमेंटम, ठीक है ना. तो वो सारे कंसेप्ट आप लिख करके रख लो एक जगह, क्योंकि ये थ्रू आउट योर लाइफ काम आने वाले हैं. और मैं आपको आने वाले दिनों में बताऊंगा कि आप कैसे इस चीज को प्रैक्टिकली या क्लिनिकली एम्प्लॉय कर सकते हो. आप अगर ये सोच रहे हो कि अगर आप एकेडमिक्स में हो या स्टूडेंट हो तभी आपको इन कंसेप्ट की जरूरत है, तो ये गलत है. अगर आप किसी क्लिनिक में वर्क कर रहे हो, किसी हॉस्पिटल में वर्क कर रहे हो, तो भी आपको इन बायोमैकेनिकल प्रिंसिपल्स का पता होना बहुत जरूरी है. मैं आने वाली क्लासेस में आपको बताऊंगा कि कैसे, ठीक है ना. अगर आप अपनी थोड़ी सी क्रिटिकल थिंकिंग लगाएंगे तो शायद आप अब भी इस चीज को जान सकते हैं कि क्यों आपको इन सारी चीजों की जरूरत पड़ेगी, ठीक है. तो चलिए, हमने अभी जो थोड़ी देर पहले बात की थी, आई जस्ट हैड अ वर्ड विद यू पीपल अ फ्यू मोमेंट्स बैक which said that we have larger medial condyle and we have meniscus also over the condyles, which enhances the surface area, which dampens it also, and it increases the surface area also. Yes, perfect, very good. The law of parsimony that you have written, that's correct. Okay, so that is what is written. Additionally, the articular surface on the medial tibial plateau is larger than the articular surface of the lateral tibial plateau, decreasing the force per unit area applied to the medial tibial plateau, which bears more force than the lateral plateau in the upright stance. क्योंकि जब हम खड़े रहते हैं, when we are standing, the whole weight is falling directly over the knee, and the weight has to be distributed between both the condyles. अगर मैं खड़ा हूं तो वजन सीधा डायरेक्टली मेरे नी पर आ रहा है, और अगर नी पर आ रहा है तो उसे इक्वली और एफिशिएंटली डिस्ट्रीब्यूट करना बहुत जरूरी है दोनों कॉन्डाइल्स के बीच में. तो अगर मैं दोनों कॉन्डाइल्स के बीच में उसे एफिशिएंटली डिस्ट्रीब्यूट करूंगा तो ज्यादा फोर्स जो है वो हमेशा मीडियल साइड में आएगा. क्यों? क्योंकि मीडियल साइड का कॉन्डाइल बड़ा है, लेटरल साइड का कॉन्डाइल छोटा है. तो जो बड़ा कॉन्डाइल है, द कॉन्डाइल व्हिच इज बिगर, ऑल्दो इट विल बी हैविंग लार्जर फोर्स, बट the distal articulating surface should also be a little more larger than its original position, so as to reduce the amount of pressure and so as to reduce the amount of compressive force that exists between both the articulating surfaces. अगर हम ऐसा नहीं करेंगे तो डीजनरेशन स्टार्ट हो जाएगा. डीजनरेशन का मतलब होता है आर्थराइटिक चेंजेस. ओके, आर्थराइटिस जिसको कहते हैं, ऑस्टियोकॉन्ड्रल चेंजेस जिसको हम कहते हैं. इसका मतलब जो आपका आर्टिकुलर कार्टिलेज है, उस कार्टिलेज का वेयर एंड टेयर स्टार्ट हो जाएगा वहां पर, ठीक है. नाउ द tibia's medial articular surface is highly concave, however is highly concave, okay, slightly concave, I'm sorry. एक्चुअली मैंने आपसे स्टार्टिंग में भी कहा था, और आप इस पिक्चर में देख भी सकते हैं. if you can see in this picture, the surfaces, these proximal surfaces of both sides, both the condyles are pretty much flattened. But there are some studies, there are some cadaveric studies that suggest you that the medial tibial condyle is very little, but very slightly, but it is somewhere concave in nature, so that it can bear a lot amount of weight and it can be a little more geometrically congruent. All right, so this is what is we need to talk about the tibia. Now the third and the very important bone when we talk about the knee complex, okay, because the knee complex has two joints basically. Okay, it has your tibiofemoral joint also and patellofemoral joint also. Okay, and there are a few books that also includes that. It has your proximal tibiofibular joint also that comes in the knee complex. All right, now When we talk about patella is a sesamoid bone. And I know that everybody of you must be knowing that sesamoid bone is a bone that does not have any bony connection, and it is the bone which has developed as a result of increased calcification within a tendon. Okay, it has developed within a tendon. Now, can you tell me? I'll just give you 10 seconds now. Can you people tell me what is the biomechanical significance of the patella? What is the biomechanical significance of patella or any sesamoid bone? Your time starts now. If you can tell me what is the biomechanical significance of either patella or any sesamoid bone, I would say. Especially let's talk about patella. Tell me what is the biomechanical significance of presence of patella. If you can tell me, I am waiting for your answers. It works as a pulley. Okay, what works does a pulley do? What works does a pulley do? Everybody knows that patella is an anatomical pulley. For extension mechanism, okay, what does it do in extension mechanism? What role does it play in extension mechanism? Add mechanical advantage. How does it add a mechanical advantage? Okay, it's anatomical pulley, but how? What is the work of an anatomical pulley? I can see your answers. Ardra Saxena, wonderful. Very good. It alters the momentum. Yes, because it is moving. See, the original not only increasing momentum, it alters the momentum. When required, it reduces the momentum. When required, it increases the momentum. Okay. So the primary attachment of all the tendons of quadriceps is on the superior base of the patella or superior aspect of the patella. Okay, so whenever you go into flexion, patella goes away. Patella goes away from the fulcrum, or it goes away from the mediolateral axis, and it eventually increases the momentum of the extensors. Okay, so when it increases the momentum of the extensors, the torque for extension increases. So whenever you are more you go more into flexion, as soon as you go more into flexion, the torque for the extension or the torque for the quadriceps increases a lot because of the increase in momentum. All right, but whenever you come down into complete extension, the patella comes back towards towards the fulcrum or towards the mediolateral axis. That is the reason why in the complete extension or in the last 10 to 7 degrees of extension, the activity of quadriceps is very low because of the lesser momentum. Why the momentum is lesser? Because patella has came back to its original position. All right. So this is the work of the patella. All right. Patella makes the joint with the femoral condyle. Okay. So it has 3 articulating surfaces. Classically, when we talk about patella, we only talk about 2 articulating surfaces that lies on the inferior surface of patella or retro surface of patella. Okay, we also call it as a retropatellar articulating surface. Okay, so it makes the joint with the distal articulating surface of the femur. So there is a ridge which is present in the center of the patella that divides the inferior surface of patella in 2 halves. The medial part is a larger part which has to articulate with a larger medial condyle that is known as medial facet of the patella. And relatively smaller part is the lateral part that is known as, or the lateral depression I would say, and it is known as the lateral facet of patella. As you can easily see in this picture, this is the lateral facet and this is the medial facet. If you can see this picture, posterior surface, this is the ridge that is dividing it into 2 parts. This is the medial part and this is the lateral part. Now, there is another depression which comes out from the medial facet that is known as the odd facet. Odd facet is called odd facet because there is only one instance during the sagittal plane motion of the knee joint when this area, when just this area remains in contact with the articulating surface of femur, rest none of the area of patella is in contact. Okay, So there is one part when we'll be talking about all this, when we'll be talking about the kinetics and the other parts of the patellofemoral motion, we'll be taking this in detail. Okay, this is the reason why this is known as the odd facet. Okay, now what does this suggest is, although the patella protects the quadriceps tendon from excessive friction from the femur during the knee flexion, its primary function is to increase the angle of force application and consequently the momentum of the quadriceps tendon. If you can see this, if you can read it out easily, so I have written this. Okay, so its main work is to increase or alter, I would say it has a very significant effect on alteration of the momentum of the quadriceps muscle. Now, estimated reductions of 33 to almost 70% in the quadriceps muscles momentum when the knee is extended are predicted with the removal of patella. Now, there is a surgery which is being done after comminuted fracture of patella, that's called patellectomy. So, in very usual cases, the apex of patella is being removed. A very small piece of patella is being removed. That is called, that surgical procedure is called patellectomy. Now, because of that patellectomy, you could see disastrous changes in the force of application by the quadriceps. And there is a very evident fact that this is the reason why, because the patella cannot function properly after that, and because of this reason, you have a significant reduction in the terminal extension range of motion of the knee joint, which is known as the extension lag. Okay, the extension lag is because of the removal of one small part of patella from its place following a patellar comminuted fracture. Okay, now you can see that when a very small part is removed, there is a significant change in the range of motion and significant change in the momentum of the quadriceps muscle and the force which is being generated by the quadriceps muscle. Okay, so although the bone is very small, but it is of very much functional importance. All right, so you must know things about patella also, and about the patellofemoral joint as well. All right. Now this is the patella. This is the superiorly taken picture of the patella, and on the right you can see that there is a movement of the patella whenever we are going into flexion. So patella is dragged inferiorly whenever you go into flexion, and it comes down to its own position when back to its own position or superior position when we come into extension. And at the complete extended position, ideally patella is a total free body. It is a free body to move. Okay, it is somewhere lying over the intercondylar notch or even proximal to the intercondylar notch, but it is not but it is not fixed over one surface. It is very free to move. This is the reason why whenever the patient is in resting state of extension, you can easily move the patella. On the contrary, when the knee goes into 15 to 20 degrees of flexion, it gets lodged completely into the intercondylar notch. And that is a position when you apply a maximum pressure also, you'll not be able to move the patella either in medial lateral directions or superior inferior directions anyhow. All right. So this we'll be studying when we'll be talking about the patellofemoral joint today. Now, the screw home mechanism is described as the final medial rotation of femur. Although we'll be talking about screw home mechanism a little later, but I'll give you some characteristic parameters of screw home mechanism just right now. Okay. Now, during flexion, as the femur rolls, okay, it is telling you about screw home mechanism. Now, let me discuss screw home mechanism in detail with you. We know that the medial femoral condyle is a larger condyle compared to the lateral femoral condyle. Okay, suppose it is a this one is a very small lateral condyle and this one is a very large medial condyle. Okay, it is like this. Okay, small lateral condyle and a large medial condyle, and this is tibia which is articulating it. Okay, now it is in flexion. Now, whenever it is coming into complete extension, this will complete its rolling earlier because of its short structure, but this area will take time to complete its rolling because of its larger structure. Okay, if you're not able to see, I'll just show it to you. If whenever I'm talking about a structure that is coming or the knee that is coming from flexion to extension, this is a smaller structure, so it will complete its rolling mechanism or rolling motion little earlier because of its short structure, and this larger structure will take time to complete its rolling. So whenever this is the tibia which is coming into extension, so this complete movement has been performed, has been completed on the lateral side, on the lateral condyle, but this is still the medial condyle of the tibia still keeps on moving, okay, to complete the rolling over the larger medial condyle. Now, so as to complete the rolling on the larger medial condyle, what the tibia do is tibia performs a lateral rotation. So tibia performs a lateral rotation on the terminal extension so as to complete the rolling and complete the larger surface area of the medial condyle. Okay, now this mechanism happens in last 15 to 20 degrees of the extension motion, terminal extension motion. This happens. This is known as screw home mechanism. It means the tibia has to perform a transverse plane motion in the terminal extension so as to complete the extension range of motion, and at the same time when the extended knee goes into flexion, the tibia has to undergo an internal rotation, slight internal rotation first, so as to start rolling on the larger medial condyle, and eventually after it moves on to say some 25 to 30%, it covers the 25 to 30% of the larger medial condyle, then the classical sagittal plane motion of flexion restarts. Okay, so always remember, when we are talking about the open kinematic chain, it means the tibia is free to move and the femur is still. So in the terminal extension range of motion, in the last 15 to 20 degrees of motion, the tibia rotates externally so as to complete the extension range of motion. At the same time, when the flexion has to be initiated, or in the first 10 to 15 degrees of flexion, first the tibia undergoes internal rotation and then the flexion of tibia starts. Okay, that is a quite easier thing what we are talking about, but this was only about the open kinematic chain when the tibia was free to move. Now, what happens when tibia is fixed and femur is moving? That is in the closed kinematic chain. Okay, when does it happen? Can you tell me an example or an exercise that includes the closed kinematic chain knee flexion? Everybody can write it in the comment box. Fast. Which movement or which exercise requires closed kinematic chain knee flexion? 10 seconds. 10. Very good. Squats. Very good. Very good. Very good. All of you are correct. Very good. So that is squats. So when we are doing mini squats, half squat, or larger squats, or full squat, it's squat. It's not squat. Okay. So whenever we are doing squatting, it is the closed kinematic chain knee flexion. Now, whenever we are going into closed kinematic chain extension, that is, we are coming from the squat, मतलब मैं पहले नीचे बैठा और अब मैं उठ रहा हूँ, तो जब मैं उठ रहा हूँ तो नी पे एक्सटेंशन हुआ, ठीक है ना? तो जब एक्सटेंशन हुआ तो ओपन काइनेमैटिक चेन में क्या हो रहा था? टिबिया का एक्सटर्नल रोटेशन हो रहा था. अब मैंने टिबिया को पकड़ दिया वहां से, तो टिबिया एक्सटर्नली रोटेट नहीं की, तो रिलेटिव मोशन फीमर में क्या हो गया? उल्टा, फीमर इंटरनली रोटेट कर दी. नाउ so as to accomplish or so as to complete the terminal extension range of motion in closed kinematic chain, the femur has to rotate internally. Okay, the screw home mechanism tells you that whenever you are going from flexion to extension in the terminal range of motion of the extension, the femur rotates medially or internally at the last 10 to 15 degrees of extension. Terminal extension 15 to 20 degrees. All right, there is internal rotation of the femur. Similarly, in the closed kinematic chain, when we initiate flexion, the femur rotates externally or femur rotates laterally a little. Okay, all right. I think that must be clear to you all people. Okay, should I write it here? I don't think I need to write it. We'll just discuss it later. हम बाद में लिखेंगे इस चीज को. अभी एक slide आएगी खाली ना. Okay, now let us see what has been written here. Now, during flexion, as the femur rolls into flexion, it rotates laterally with respect to the tibia. Okay, that is the closed kinematic chain. Okay, the femur rotates medially as it rolls into extension. Right? Clear, everybody? Now, contact between the femur and tibia migrates posteriorly on the tibia during flexion and anteriorly during extension. It's okay. That's pretty much a simpler thing. There appears to be some anterior-posterior translation between the tibia and femur during some portions of flexion and extension. Yes, we all know that. Whenever, because of the concave convex rule, we all know that there is a translation of the tibial plateau anteriorly when we go into extension and posteriorly when we go into flexion. Okay, this is governed by the concave convex rule, and I suppose you all know that the concave convex rule. Okay, which part of the convex concave rule will be applicable in the knee joint? In the open kinematic chain motion of the knee joint, which rule of the concave convex rule will be applicable? Write it in the comment box. Fatafat, jaldi. Which rule of the concave convex rule will be applicable when we talk about the open kinematic chain movement? Okay, rolling of what? Here the moving surface is tibia, and tibia is either flat or concave. Okay, now the convex surface is fixed, but the concave surface is free to move when I'm talking about open kinematic chain. Okay, so when concave surface move over the convex surface, yes, you have written correctly. The rolling and sliding will be in same direction. Very good. The rolling and sliding will be in same direction. So whenever we are coming from flexion to extension, the rolling and sliding of the tibial articulating surface will be anteriorly. That will be coming forward. Okay, and whenever we are going into flexion, the rolling and sliding will occur posteriorly. That is what has been written over here, and this is the basis of the the arthrokinematic motion at the knee joint. Right. So this is what you need to learn. So in this picture, you can see here that there is a significant rotation which is being taught. See, whenever in open kinematic chain it is going into flexion, so the tibia is undergoing an internal rotation before it starts going into flexion. And whenever it is coming back into extension, see the tibia is going into external rotation. Okay, so I can write it here. Extension is equals to external rotation of tibia. Okay, and flexion is equals to internal rotation of tibia. Okay, that is in open kinematic chain. Okay, now what about in closed kinematic chain? So extension is equals to internal rotation of femur. All right, and flexion is the external rotation of femur. That is in closed kinematic chain. Easy. That becomes easy for you people now. I don't think any complications are there. Okay, now let us move forward. Now coming on to the soft tissues, there are a lot of soft tissues present around the knee joint. I don't need to name it, you will know that. Almost around say 13 ligaments in capsule and 14 bursa and other articular cartilages. There are lot more other soft tissues, but we'll be discussing the soft tissues which are of more biomechanical importance. Okay, correct. You all are correct. Most of you people who have written the answers in the comment box, you are correct. Okay. Coming on to the one of the most important structures of the knee joint, that is ACL, that is anterior cruciate ligament. You must have heard or you must have read everywhere or in many places that people have more prevalence of ACL injuries in both athletic population and non-athletic population as compared to any other structure at knee. है ना? हमेशा हम ये बात सुनते हैं कि हर जगह, चाहे वो सर्जिकल पॉइंट ऑफ व्यू से बात करें या फिर ट्रॉमेटिक पॉइंट ऑफ व्यू से बात करें या स्पोर्ट्स पॉइंट ऑफ व्यू से बात करें, कि एसीएल इंजरी की प्रेवलेंस सबसे ज्यादा होती है. कोई भी लिगामेंट इतना फ्रीक्वेंटली इंजर्ड नहीं होता है जितना फ्रीक्वेंटली एसीएल इंजर्ड होता है. अब आज हम जानेंगे कि ऐसा क्यों होता है. ओके, एसीएल इज अ वेरी इंपॉर्टेंट लिगामेंट that starts from the anterior aspect of the tibial spine. टिबिया के ऊपर एक बीच में रिच होती है जिसको हम tibial spine कहते हैं. तो उसके anterior aspect से शुरू होकर के posterolateral aspect of the femur तक जाता है. फीमर का जो लेटरल कॉन्डाइल होता है उसके मीडियल सरफेस की तरफ तक जाता है. ठीक है ना? और एसीएल में दो बैंड्स होते हैं हमेशा. One is called anteromedial band, that is AMB. The other one is पोस्टेरोलेटरल बैंड, दैट इज पीएलबी. तो जब भी हम यूजुअली क्या बात करते थे आज से पहले, जब भी हमने एसीएल के बारे में सुना था कि एसीएल रेस्ट्रिक्ट्स द एंटीरियर ट्रांसलेशन ऑफ टिबिया. आज हम एक बात जानेंगे कि एसीएल इज वन ऑफ दोज लिगामेंट्स व्हिच रेस्ट्रिक्ट्स द एंटीरियर ट्रांसलेशन ऑफ टिबिया आल्सो, restricts the posterior translation of tibia also, it restricts the medial migration of tibia also. यही रीजन है कि अगर आप वैल्गस फोर्स लगाओगे तो भी एसीएल इंजरी हो जाएगी, अगर आप एंटीरियर फोर्स लगाओगे तो भी एसीएल इंजरी हो जाएगी, पोस्टीरियर फोर्स लगाओगे तो भी एसीएल इंजरी हो जाएगी, और अगर कोई टॉर्शनल फोर्स लग गया टिबिया के ऊपर, आजकल वो बच्चे नहीं करते, कई टीवी में अगर आप देखते होगे कि ना एक बाइक का हैंडल पकड़ा और एक पांव जमीन पर रख के ऐसे घुमाते रहते हैं, उसमें सिंगल स्टांस फेज में खड़े होते हो आप. यू आर स्टैंडिंग ऑन सिंगल लेग, you are having weight bearing on your single leg. So whenever you are having weight bearing on your single leg, there are enormous amount of torsional forces in such cases. गाड़ी घुमाने में there are enormous amount of torsional forces that acts on the knee joint along with the compressive loading of the knee joint over there. Okay, so in those cases you must consider that there could be a possibility of ACL injury at that time. All right. So I was talking about that the ACL courses posteriorly, laterally, and superiorly from tibia to femur. In addition, the ACL twist inwardly or medially as it travels posteriorly. Okay, ये थोड़ा सा ट्विस्ट होता है मीडियली. अब ट्विस्टिंग की वजह ये है कि जो दोनों बैंड्स होते हैं, the two bands that I was talking about, the AMB and the PLB band, they are intermingled with each other, they are coiled within each other. जैसे ऐसे लड़कियां छोटी बनाती है ना, बिल्कुल वैसे ही they are coiled within each other. Okay, तो दोनों ही coiled होते हैं, such that some part of ACL is in tension in every motion. Okay, be it any rotation, be it any sagittal plane motion, कोई भी motion हो रहा है या frontal plane motion हो रहा है, तो हर motion में at some point of time, some given time, there is some part of ACL which is under tension. All right. So it says that the ACL may also be considered to consist of two separate bands that wrap around each other. Each of these bands is thought to have a different role in controlling the tibiofemoral motion. That's what I told you. The anteromedial band and the posterolateral band. Okay. Now with the knee in full extension, the posterolateral band is taut. It means whenever the tibia moves anteriorly, that's what I told you. Whenever the tibia moves anteriorly, the band of ACL that is taut is your PLB band, and when it goes posteriorly, the AMB is the band which is taut. Okay, that is the anteromedial band that becomes tight. Okay, that is under tension. Okay, so either it is flexion or it is extension. At some part of time, one part of ACL is always under tension. So you never say that the distinguishing point between ACL and PCL is that ACL restricts extension and PCL restricts flexion. No, ACL restricts both flexion and extension. Although PCL also has these two bands, but it has more of its restriction towards the posterior migration of tibia. Okay, now 30 degrees of flexion is a position. Note this point. 30 degrees of flexion is that position when both these bands are a little relaxed. Okay, when they are in a relaxed position, or you can say that the relative tension in these two bands are less. इसका मतलब 30 डिग्री ऑफ नी फ्लेक्शन एक ऐसी जगह है, एक ऐसी पोजीशन है जहां पर ये दोनों बैंड्स थोड़े थोड़े कम हो जाते, मतलब थोड़े थोड़े रिलैक्स हो जाते हैं, थोड़े थोड़े रिलैक्स हो जाते हैं। इसका मतलब एक वो जगह है जहां पे अगर आपको कोई टिबियल मोशन चेक करना है या किसी दूसरे सॉफ्ट टिश्यू की इंटेग्रिटी चेक करनी है तो इट इज अ सेफ जोन। इसका मतलब वो टूटेगा नहीं। यूजुअली हम लोग जब भी बात करते हैं टेस्ट की, जो कि एसीएल टीयर की हम बात करते हैं, तो दो टेस्ट हमारे दिमाग में आते हैं। सबसे पहला जो टेस्ट आता है वो आता है लैचमैन्स टेस्ट, और जो दूसरा टेस्ट हमारे दिमाग में आता है वो आता है एंटीरियर ड्राउट्स टेस्ट। मैं हमेशा कहता हूं एंटीरियर ड्राउट्स टेस्ट इज अ प्रोवोकेटिव टेस्ट, बट लैचमैन्स टेस्ट इज नॉट अ प्रोवोकेटिव टेस्ट। क्यों? क्योंकि जब मैं टिबिया को प्रॉक्सिमली पकड़ के आगे खींचता हूं लैचमैन्स टेस्ट में, तो मैं 30 डिग्रीज ऑफ नी फ्लेक्शन पे होता हूं। तो इसका मतलब ये वो पोजीशन है जहां पे एएमबी और पीएलबी दोनों बैंड्स रिलैक्स हैं, रिलैक्स स्टेट में है, टेंशन इतनी ज्यादा नहीं है। तो टेंशन अगर इतनी ज्यादा उसमें नहीं है उस समय, तो मैं उसको पुल थोड़ा सा कर सकता हूं। लेकिन अगर वही मैंने इसका फ्लेक्शन बढ़ा दिया और फिर मैं पुल कर रहा हूं, तो कोई ना कोई लिगामेंट, कोई ना कोई बैंड जो है वो अंडर टेंशन होगा, और जो भी बैंड अंडर टेंशन होगा मैं खींचूंगा उसको, नी को, एंड इट विल इंक्रीज। So that could have become a provocative test. Okay, in that case, whenever I increase the range of motion of flexion to test the integrity of the ACL anterior cruciate ligament, it can be a provocative test. मतलब जो पेशेंट था मेरे पास ग्रेड 2 के साथ आया था, मैंने 60 डिग्रीज ऑफ नी फ्लेक्शन में खींच दिया और उसको ग्रेड 3 कर दिया। So that became a provocative test. Okay, so always remember 30 degrees of knee flexion is a position where both these bands of ACL ligaments are relatively relaxed. Okay, now in addition to its primary restraint against anterior shear, the ACL can act as a secondary restraint against the varus or valgus motion also. That is what I told you. अगर ये medially migrate हो रहा है तो भी, अगर टिबिया medially जा रही है तो भी I would say कि प्राइमरी सेकेंडरी रेस्ट्रेनिंग स्ट्रक्चर, ये जो एसीएल जो लिगामेंट है वो टेंशन में आएगा, और अगर लेटरली जारी है तो भी एसीएल जो है वो टेंशन में आ जाएगा। ओके, नाउ विद वैल्गस लोडिंग द लेंथ ऑफ बोथ द बैंड्स ऑफ एसीएल इंक्रीजेस। अगर मैं मीडियल साइड से धक्का लगाऊं और उसको लेटरल साइड में माइग्रेट करा दूं टिबिया को, तो ये वो कंडीशन होती है जहां पे एएमबी भी टाइट हो जाता है और पीएलबी भी टाइट हो जाता है। ठीक है ना? और यही वो रीजन है कि जब भी मैं बात करता हूं एमसीएल इंजरी की, जो कि बहुत कॉमनली होती है वैल्गस स्ट्रेस के कारण, तो हमेशा एसीएल, यूजुअली एसीएल जो लिगामेंट होता है वो भी साथ में टियर आपका पाया जाता है। इसका एक रीजन और भी है कि जब मैं एमसीएल की बात करता हूँ, मीडियल कोलैटरल लिगामेंट की बात करता हूँ, तो मीडियल कोलैटरल लिगामेंट में हमेशा दो बैंड होते हैं, एक होता है सुपरफिशियल बैंड और एक होता है डीप बैंड। तो जो डीप बैंड होता है एमसीएल का, वो कहीं ना कहीं मीडियल मेनिस्कस से चिपका हुआ होता है, और मीडियल मेनिस्कस का जो एंटीरियर हॉर्न है वो कहीं ना कहीं लगा हुआ होता है आपके एंटीरियर पोर्शंस ऑफ योर एसीएल के साथ, तो एक से दूसरा चिपका हुआ है। तो जैसे ही आपका डीप बैंड ऑफ एमसीएल टूटता है, वो एक पुल एक्सर्ट करता है एंटीरियर हॉर्न ऑफ योर मीडियल मेनिस्कस पे, और वो फोर्स कहीं ना कहीं जाता है एसीएल के ऊपर। ठीक है ना। तो वो डीप बैंड ऑफ एमसीएल जो है, अगर फोर्स ज्यादा है तो वो एंटीरियर हॉर्न ऑफ मीडियल मेनिस्कस को भी टियर करता है और कहीं ना कहीं आगे जाकर के एसीएल को भी टियर करता है। It is also known as O'Donnell's triad or unhappy triad of knee because of the injury of three soft tissue structures at the knee. All right, becomes easier thing for you people. Now, medial rotation of the tibia on the femur increases the strain on AMB of the ACL with a peak strain occurring between 10 to 15 degrees of flexion. अगर मैं 10 से 15 डिग्रीज ऑफ फ्लेक्शन तक में टिबिया का मीडियल रोटेशन कराता हूं तो AMB is the band which comes under great tension. AMB is that band of ACL which comes under great tension at 10 to 15 degrees of knee flexion. All right, you can see here the action of ACL, and along with that you can also see the action of PCL. All right, so they are easier ligaments to be understood. Okay, now these are the muscles that corresponds with the action of these ligaments. Okay, now suppose this is the cross for ACL and PCL. So we always say that ACL is one ligament which restricts the anterior translation of the tibia. Suppose this is your tibia. I'm looking laterally into it, okay, and this is your femur. Okay, now this is the anterior translation which is being restricted by your ACL. Suppose this was ACL. Now, which can be the other structures that would help to restrict this motion, anterior motion? The structures which would be lying on the posterior aspect or which would be having a posterior pull on the tibia, that would be your hamstring. Okay, hamstring is one muscle that lies on the posterior aspect of the tibia and pulls the tibia back. Similarly, the other muscle is your soleus muscle that lies onto the that takes its original from the posterior aspect of the tibia and later on forms a major component of the calf muscles. All right, so this is another muscle that has a posterior pull on the tibia. Although the direction of force is different for both the muscles, but both of these muscles have a posterior pull on the tibia. Eventually, it restricts the anterior translation of tibia. So whenever you are having a torn ACL or whenever there is a patient who's rehabilitating for ACL reconstruction, you must account for the strengthening of hamstring muscle also and your soleus muscle also. So these are the two muscles which must be strengthened whenever we are talking about the rehabilitation of ACL either reconstruction or ACL tear. All right. Similarly, when I talk about the opposing force of it, or the force on the muscle that redirects or that corresponds the function of the posterior cruciate ligament, that is your quadriceps, because posterior cruciate ligament prevents the posterior pull, and the posterior pull is somewhere prevented by the action of quadriceps also. Although quadriceps gets its insertion on the patella, and eventually patella has a patellar tendon or patellar ligamentum patellae that inserts at your tibial tuberosity. So eventually this area, this is that area which is the continuation of your quadriceps tendon, which eventually prevents the tibia on while going into posterior translation. All right, so these are the muscles that correspond to that particular motion. Next is your posterior cruciate ligament. Posterior cruciate ligament, let us not talk about only posterior cruciate ligament, because whenever we have mechanisms like dashboard injury or mechanisms like straight posterior blow on the tibial tuberosity from anterior side, especially in case of sports and especially rugby and American football. There are a lot of or football, normal football also, or hockey, such things happen. Okay, in that case, PCL is not the only structures that gets injured singly or that's isolatedly goes into injury. All right, it is the whole posterolateral complex that goes into injury. Now, posterolateral complex involves posterior cruciate ligament also. It involves oblique popliteal ligament also. It involves arcuate popliteal ligament also, and the posterior capsule also. Because it is that particular area which is not that much strengthened with the thickening of the capsule or presence of too much of muscles to make that area a little thicker. All right. So this is that particular area, posterior lateral complex of the knee, which gets injured whenever we talk about the mechanism that we discussed. Okay. Now let us see what I've written here. The PCL attaches distally to the posterior tibial spine and travels superiorly and somewhat anteriorly to attach onto the lateral aspect of the medial femoral condyle. Now you must get to know why these two ligaments are known as cruciate, because they are entirely opposite in their origin also, insertion also, and their course also. All right, they are crossing each other in different directions. The PCL starts on tibia posteriorly and it migrates anteriorly and medially. Okay, onto the medial femoral condyle, the lateral aspect of the medial femoral condyle. All right. So the migration is entirely opposite as to the compared to the ACL. It was going laterally. Now this is going medially. Okay. Let me tell you, these two ligaments are extra synovial ligaments. They come out of the synovial membrane. Okay, that's written in the next point also. Now the PCL is a shorter, less oblique structure than ACL with a cross-sectional area of 120 to 150% greater than that of the ACL. This is one of the important reasons why ACL injury is more common as compared to PCL injury. Okay, PCL or the posterior lateral complex injury is not that common a thing when we talk about the injuries of the knee joint. All right. Now, the PCL blends with the posterior capsule and periosteum as it crosses its tibial attachment. The PCL, again, like the ACL, is typically divided into AMB and PLB that are each named after their tibial origins. Okay. When the knee is closed into full extension, the larger and stronger AMB is laxed. Okay. Whenever the tibia has migrated anteriorly, the AMB band of the PCL is laxed, whereas PLB becomes taut at the complete extension. So at the complete extension, posterior lateral band of the PCL, that is posterior cruciate ligament, is relatively tight, okay, to pull the tibia back. Now, at 80 to 90 degrees of flexion, the anteromedial band is maximally taut and the PLB is relatively lax. Okay, it is relatively lax. It is in a relaxed state. All right. So this is what we need to know about the posterior cruciate ligament. All right. So this is what is the posterior cruciate ligament we see here. This is a larger posterior cruciate ligament. Okay, this one, and this is the larger anterior cruciate ligament also. Okay, here you can see the structures. This is your PCL, this one is your PCL, and this one is your ACL. Okay, ACL, and this one is your PCL. All right, so you can easily know what could be the functions of it. Okay. Now, very important thing, meniscus. I'll not be telling you anything about the anatomy of meniscus, because you people know about the anatomy. Which one is the half ring, which one is the C shape, which one is the 2/3 part of the ring. I'll not be telling you. Okay. So we have a larger medial tibial condyle. We have a larger medial femoral condyle. Now, so as to approximate the larger medial femoral condyle, we require a larger surface area over the tibia. Now, medial meniscus helps us to, although meniscus has a lot of other actions of shock absorbing, giving nutrition, improving the lubrication and everything like that. Along with that, the major work is to increase the shock absorbing capacity, to increase the dampening the articular surface of the tibia, and most importantly to make the articular surfaces more geometrically congruent. Ideally, at the knee joint, we do not have congruent articular surfaces. All right. So it says that while walking, the compression forces at the knee joint routinely reach approximately 2 to 3 times the body weight. So the compressive force that is lying between the knee joint during standing, walking, or performing any weight-bearing activities could reach to almost 2 to 3 times of the total body weight. All right. Now, how to cope up with that much amount of compressive loading? Now, medial or the lateral meniscus helps us to cope up because of their excellent shock absorbing capacity. It helps us to dissipate this much amount of force that is coming from superior to the inferior areas. Okay, by almost tripling the area of joint of contact because of the inclined peripheral surfaces of it. All right, the peripheral surfaces of the meniscus, or be it both medial or lateral, it has a little more inclined surface from peripheral to central. It increases the surface area. It increases the area of articulation. Okay, that is how it reduces the pressure which is coming inside the joint, between the joint. Okay, now a complete lateral meniscectomy. Meniscectomy का मतलब होता है removal of meniscus or removal of a part of meniscus. It usually happens whenever there is a chronic injury. जब आपको इंजरी हुई, आपने ध्यान नहीं दिया, चलते फिरते रहे, फिर कुछ भी नहीं कराया और हम बढ़ते गए आगे, साल, 1.5 साल, 2 साल हो गया, 2 साल के बाद वो टीयर बढ़ गया, अब इतना बढ़ गया कि वो रिपेयर की कंडीशन में नहीं है. तो उस एक कंडीशन में जो एरिया खाली पड़ा होता है, हिल रहा होता है, बीच बीच में आ रहा होता है जॉइंट को, उसको हम काट के निकाल देते हैं वहां से. तो उस प्रोसीजर को हम कहते हैं मेनिसेक्टमी. ओके, नाउ अ कंप्लीट लेटरल मेनिसेक्टमी इंक्रीजेस the peak pressure lying between that particular compartment to almost 230%. जो नॉर्मली होता है, नॉर्मली हमने क्या कहा, 2 to 3 times of body weight होता है. तो अगर 2 to 3 times of body weight नॉर्मली है और उसके बाद भी मैंने कुछ एरिया ऑफ मेनिस्कस हटा दिया है, तो वो उस 2 to 3 times ऑफ बॉडी वेट के भी 30% ऑफ बॉडी वेट को बढ़ा देता है. मान लो मेरा बॉडी वेट 60 kgs है, तो नॉर्मली जब मैं वॉक कर रहा हूँ, चल रहा हूँ, तो मेरे नी जॉइंट पे जो कंप्रेसिव लोडिंग आ रही है, दैट वुड बी इक्वल टू समवेयर 180 kgs. ऑलराइट, नाउ अगर मेरा मेनिसेक्टमी हो गया है, तो इट वुड इंक्रीज द कंप्रेसिव लोडिंग बाय अनदर 200%. इसका मतलब 180 plus 180. So now the force which is acting between my knee joint could be somewhere nearly around your 360 kilograms by just removal of one area of your meniscus. All right. Now each menisci support to half of the total load being imposed on the knee joint. Okay, so जो आपका meniscus होता है, it helps very efficiently to bear a load between coming in your knee joint. Okay, coming on to the kinetics or kinematics of the knee joint, that will be the last portion of today. So we all know that when we're talking about the osteokinematics, ideally when we talk about this condylar variety of joint, there is 1 degree of freedom, that is the sagittal plane. When we have flexion and extension, the axis of rotation is mediolateral axis around which the movement takes place. But there are a few studies, there are a few books that says that there is a significant motion of the tibia in the transverse plane as well. So you can isolatedly perform rotations of the tibia as well. So you have a rotational movement, medial lateral rotation also, but it is in a situation which is not that easily measurable. So we consider that we have flexion and extension range of motion at the knee joint, which occurs around the medial lateral axis. Now, whenever I talk about either the open kinematic chain or the closed kinematic chain motion, the axis of rotation, that is the axis of rotation of the knee joint, the medial lateral axis, which is being marked over here like this. Okay, it is not a fixed axis because of the relative migration of patella anteriorly. The medial lateral axis of rotation of the knee joint keeps on changing when you go from extension to flexion, or you come back from flexion to extension. Okay, in complete extended position, the axis lies somewhere here. Eventually, in mid flexion position, it reaches somewhere here, and in complete flexed position, it reaches somewhere here. So from extension to flexion, it follows a curvy linear path, and this curvy linear path is known as evolute. Okay, the curvy linear path of the axis of rotation, the medial lateral axis of rotation of the knee joint in the sagittal plane is known as evolute. Okay, that is what we call it. I call it as instantaneous axis of rotation. At one given time, it will be different at different given times. Okay, so at one given time, it always has a different medial lateral axis of rotation in the sagittal plane. Okay, now the migrating axis alters the internal momentum of the flexor and extensor muscles. All right, this is the patella that is trying to alter all the momentums. Now, because of the relative position of patella, the axis also migrates, and which eventually changes the momentum of the hamstring muscle, also the momentum of the quadriceps muscle also. Okay, so this is what is the celebration studying this. Now, this kinematics of knee joint is completely dependent on the screw home mechanism that we have already studied. And what I told you that whenever this whenever we talk about the open kinematic chain motion, the tibia goes into flexion. Whenever tibia goes into flexion, the concave part of the tibia moves over the convex part of the femur, and in flexion both rolling and sliding occurs in posterior direction, and whenever the tibia comes back into extension, the both rolling and sliding occurs in anterior direction. But whenever I talk about femoral on tibial extension or flexion, in that case the convex surface moves over the concave surface. All right, so it moves like this. All right, it moves like this in flexion, and it moves like this in extension. So whenever I talk about the femoral on tibial motion, the rolling and sliding occurs in opposite direction. Okay, so whenever I'm coming back to extension in closed kinematic chain, the rolling occurs anteriorly and sliding occurs posteriorly. And whenever I go from extension to flexion, the rolling occurs posteriorly and sliding occurs anteriorly. Okay, it will be like somewhere like this. Okay, so you have different directions of motions for rolling and sliding when we talk about the closed kinematic chain, but it is in the same direction when we talk about the open kinematic chain. The next kinematics is just screw home mechanism, and you people know about it. Coming on to the very important aspect of the kinematics of the knee joint, that is your patellofemoral joint kinematics. Patella, as I told you, changes its position or relative position as soon as we go into flexion from extension, or we come back from flexion to extension. All right. So what does it say is articular side of patella articulates with the intercondylar group, that is the retropatellar surface, or the inferior surface of patella articulates with the intercondylar groove. Okay, now during flexion and extension, the articular surface of patella slides over the intercondylar groove. This is the intercondylar groove. You can see it in the picture from where the inferior surface of the articular surface of the patella is sliding. So it is the intercondylar groove where it is sliding down. So whenever the knee joint goes into flexion, the patella, this area, the direction of migration of patella is towards inferior aspect. Okay. Now, at 135 degrees of flexion, that is complete flexed position of the knee joint, the superior pole of the patella contacts the femur. Only it is the superior pole. If you can see this picture, at 135 degrees of the flexion, only this superior pole of patella is in contact with the femur. Now, at flexed position, patella lies below the intercondylar groove. In the complete flexed position, this is the intercondylar groove, and patella lies below, distal to the intercondylar groove in the complete flexed position. Okay, bridging the intercondylar notch. If this is the intercondylar notch, it attaches onto both the ends of the intercondylar notch, bridging the intercondylar notch. Okay, this is how. Now at this point, the lateral edge of the lateral facet and the medial edge of the medial facet. The medial edge of the medial facet was your odd facet of the patella that we studied earlier. Okay, now lateral edge of the lateral facet and the odd facet is in contact with the femoral articular surface. All right, this is what is the significance of your patella, or this is what is the significance of your articular odd facet of the articular surface of patella. Now, as the knee moves towards extension, the patella migrates superiorly, and between 90 to 60 degrees of extension, the patella has greatest contact area with the femur. It means that largest area of contact, the surface area, highest amount of surface area has contact with the femoral articulating surface in the patellofemoral joint between 90 to 60 degrees of knee extension. From 90 degrees of knee extension, when it is coming back till 60 degrees of knee extension, it has largest surface area contact. It means that whenever you perform exercises in between this range from 90 degrees of knee flexion to 60 degrees of knee flexion, the surface area and contact will be larger. So the relative pressure will be lesser. So all those patients who are suffering from patellofemoral arthritis could be made to perform exercises in this region so that lesser degeneration can be opted for those patients. But what do is we start from the 90 degrees and we go for complete extension, which eventually imposes more load onto the patellofemoral joint as well. All right, if it is imposing more load onto the patellofemoral joint, it is eventually causing more degeneration at that particular area. All right, now even at the maximum contact area, only 30% of the surface area is in contact with the femoral articulating surface. So it means not even 50% of the patella is in actual contact with the femoral articulating surface. All right, now at last 20 degrees of extension, in last 20 degrees terminal extension, the contact point migrates to the inferior pole, and in last 10 degrees I would tell you that not even the inferior pole is in contact with that femoral surface area. Okay, so in full extension, patella rests over the intercondylar groove, so it is ideally not in contact with any surface area of the femur, over the suprapatellar fat pad with relaxed quadriceps. Okay, now if patella has migrated superiorly, it has came a lot more closer to the mediolateral axis of rotation of the knee joint. It means the momentum for quadriceps has dropped down. If the momentum for quadriceps has dropped down, the quadriceps will no longer be able to produce significant extension torque. All right, now at about 20 to 30 degrees of flexion, the patella gets seated into the intercondylar groove with increased tension in quadriceps and periarticular tissues. I already told you about all these things. Okay. Now, this is what I was telling you about. At complete 135 degrees of flexion, you can see here only superior pole is in contact along with the odd facet and lateral margin of the lateral facet. And at the 90 degrees of flexion, maximum surface area, the white area, if you can see that, is the maximum surface area which is in contact. And at 20 degrees and beyond, it is only the inferior pole which is in contact. And when we go beyond this, this is the suprapatellar fat pad, and the patella migrates over this and eventually is not in contact with femur anymore. Okay. Now the proximal distal alignment of patella, that is whenever the patella is aligned superiorly, it is called the patella alta. So whenever the distance between the tibial tuberosity and the inferior pole of patella increases, it is known as patella alta. And whenever the distance between the inferior pole of the patella and the tibial tuberosity reduces, this is called patella baja or patella infera. Okay, this is a deformity. Now, the last three things what I want to discuss it with you are the angulations of the patella and the knee joint. Okay, now this is the superior view of the knee joint. Always remember that I am looking from superior. Okay, from the upper aspect. ऊपर से देख रहा हूँ मैं knee joint को. So knee joint appears like this. So this is the femoral area. Okay, this is the femoral area, and this is the patella. This is the retropatellar surface or the inferior articulating surface of the patella, and this is the superior intercondylar groove rather. Okay, so the first angle that we are talking today is the patellar tilt angle. That tells you what kind of migration the patella could have. If the patella would be having any lateral deviation, lateral tracking of the patella, or if it is having any medial tracking of patella, excessive lateral tracking, I mean, because classically patella or physiologically patella deviates laterally. Okay, now what is patellar tilt angle? What we have to do is that whenever we take a superiorly lying picture of the X-ray, so we join the medial, the most medial and lateral ends of the margins of the patella. Okay, so I have joined these two lines. If people can see, okay, I have joined these 2 points and extended the line. Similarly, I have joined the superior most surface of the lateral part of the of this what you can say, but femoral groove, and the highest point on the medial part of the femoral groove. I have joined these 2 points also. Okay, na? So I have joined. I have made one line this across the patella. Now I am making this joint across the femoral groove. Now when I extend these lines meet somewhere. Now the angle those 2 lines make while intersecting is known as the patellar tilt angle. All right. This is known as the patellar tilt angle. If you have not understood, I will be telling you once again. I'll be drawing a different diagram here. Suppose this is the femur. Pardon my drawing, it is not that good. And this is the patella. So I took one point this and I took the other point this. I joined this line. Okay. Similarly, I took this highest point on this surface and this highest point on this surface. I again joined these 2 lines. Okay. Now I extended these lines to meet somewhere, and the angle these 2 lines intersecting lines made is known as the patellar tilt angle. Okay. Similarly, we have a few more angles, that is the sulcus angle. Sulcus angle eventually tells you the depth of the femoral groove. Okay, it is the deepest point of the femoral sulcus to the highest point on the condyle. Okay, so you usually make 3 points available. One is the deepest point on the femoral groove. The other ones are the highest points of the femoral groove. You join these 2 points. You join these 2 points. Now, when these 2 intersecting lines make an angle, it is known as the sulcus angle. Okay. The normal value of sulcus angle is about 125 to 155 degrees. It can vary from one gender to the another, male and female. It can vary. Okay. The last one for today is the angle of congruence. Okay. Now, what is angle of congruence? The angle of congruence is the measure of how well the patella fits into the trochlear notch of the femur. It is formed by a line bisecting the sulcus angle. The sulcus angle was the previous angle what we made. Okay, bisecting the sulcus angle and another line that projects from the apex of the sulcus angle through the peak of the patellar ridge. Okay, now let me tell you a few things. Suppose this is what is the patella. Okay, and this is okay. Let me tell you, this is the patellar ridge. This point, okay, this point, okay. Now we have to draw a line which starts from the deepest point of the femoral groove, which connects this patellar ridge, okay, which has to bisect the patellar ridge. Now, what angle does this line makes with the angle bisector of the femoral groove is your congruence angle. Okay, I'll tell this to you once again. Okay, so what happens is, suppose this is my femoral groove and this is somewhere my patella. Okay, now this is my patellar ridge and this was the point that I saw during the sulcus angle. This is the sulcus angle. Okay, suppose this is the sulcus angle. I connected this point with this point first, and then I had made a angle bisector for the sulcus angle. Okay, now the angle these 2 intersecting lines made, this angle, this small angle, okay, this angle is known as the congruence angle. Okay, I request everybody, all those people are listening to me, must remember this angle of congruence and sulcus angle and the patellar tilt angle. We'll be talking about a few more deformities in the coming classes of the knee joint and the other joints also, and the forces which are lying in between. All right, so you people must make a note of it, all those who have listened to me and all those who are listening to me till now. Okay, so this is something what we need to end here today, and if you have any questions you can write it in the comment box. I'll be taking it up right now. Any questions right now? Any questions? If you have, people can write. For any questions you can write. We'll be taking the kinetics of the knee joint tomorrow. So if you have any questions, you can write it here. If you have any questions, you can write it here. Anybody? I can take a few more moments having your questions. So if you have any questions here, you can tell me. Otherwise, we'll switch off the meeting for the day. Okay, we have a question. So how can we differentiate clinically in chondromalacia, patella, and patellofemoral osteoarthritis? Okay, see, chondromalacia of patella has a significant MRI changes, although every patellofemoral OA has chondromalacia because it's the cracking which develops, and it is an abnormal cracking which develops in a certain area. Okay, it is usually whenever we talk about osteoarthritis is always a segmental thing. Whenever we have, suppose this is the complete retropatellar surface, inferior articulating surface of patella. So if there is increased pressure at this area, there will be cracks that will be developing in this area, or fibrosis which will be available in this area. Okay, so you will have patchy type of osteochondral changes in osteoarthritis of patellofemoral joint. But if it is chondromalacia patella, there will be always a very significant distribution of all the cracks that is coming into the articular cartilage of the patella. Although it is beyond the scope of today's lecture, but still, it was a good question. Anything else? What you need to ask anybody? If you want to write anybody, I'll just stop sharing this. Okay. Anybody? Any questions? Any more questions? Do we have here? Any more questions do we have here? All right. We have almost taken a class of 1.5 hours today. So what will be another better way of celebration of Teachers' Day than this? Okay. So very happy Teachers' Day to all of you. And do well. Do make your teachers proud working in this profession of physiotherapy. I convey my best regards to everybody. All the best to all of you. Happy Teachers' Day to all of you once again. And goodbye.